Welcome to AETCM, the Emergency Medicine Channel. 61-year-old male patient presented to ER with complaint of bleeding from the nose. On initial 10-second assessment, patient was conscious and oriented. Going to primary survey, on airway, patient was able to complete full sentence. There is no pooling of secretions or gurgling. There is active bleeding from the left nostril. So at that time, we asked the patient to supine, in bending forward, sitting position, bending forward, and asked to pinch the tip of the nose. Then coming to
area of the nose.
Coming to breathing part, respiratory rate is 16 per minute.
Okay, so if in airway assessment, if patient was having gurgling, what will you do?
Suction.
Will you intubate?
Airway is not right.
The question is whether patient is conscious enough to maintain the airway. Gurgling means there is fluid there. If patient can't swallow, then it's not a problem. You just ask the patient to continuously swallow. But what will it denote? Patient is having gurgling. When you're trying to talk, when he is not talking also, if he's having gurgling, there is a problem. But if he's trying to talk and there is gurgling, what does it show? Where is the bleeding from?
Posteriorly bleeding.
You should suspect posterior END bleed rather than the anterior END bleed. Okay.
Coming to breathing part, respiratory rate is 16 per minute, saturation is 96% room air entry bilaterally equal. Coming to circulation part, heart rate is 96 per minute and BP is 160/90. That time we put a large bore IV cannula. Disability, GCS was full, people bilaterally equally reacted to light and exposure temperature was normal. So we reassess the patient. We ask the patient to pinch the area of nose for 10 to 15 minutes and ask the patient to spit out the blood to bucket place in front. Then after 10 to 15 minutes, we reassess the if any active bleeding is there.
The primary survey is over, right?
Primary survey is over.
Over, right? Okay. So you told the patient to pinch the nose for
10 to 15 minutes.
10 to 15 minutes and
ask the patient to spit out the blood coming or swallow or spit out the blood.
No. It should always be swallow, not spit out. See, the entire idea is not to increase the mobility, isn't it? You are pinching the nose and giving compression. So you are promoting clot formation. In the meantime, you don't want patient to do a nasal clearance. If the patient is going to clear his nostrils and try to suction out the blood from outside, it will again cause movement of the area and again promote bleeding only. Just ask the patient to swallow whatever blood he is getting. If patient is fully conscious, that is the question. Conscious or decreased mentation. Decreased mentation, obviously you are going to intubate because you don't know where is the source of bleeding, right? Decreased mentation, gurgling, you should suspect posterior secure airway. Aspiration should be prevented. Fully conscious, even if it is posterior, you can always ask the patient to swallow. Unless patient is actively desaturating or uncontrollable bleeding is happening, you really don't want airway securing in a conscious patient. Okay, so you ask the patient to pinch the nostril and lift up the
extend the neck area, bend forward.
Lift up the head and bend forward position. Sniffing dog position. And keep it for 10 to 15 minutes. Okay. After that, how was the patient?
After 15 minutes, bleeding was stopped. So we move on with checking from where it was bleeding. For that, we give lidocaine or we can give xylocaine, dip gauze we can insert or we can drip that. Then we can check for any bleeding point is there. So we found at anterior superior septum areal there is a bleeding spot was found. Then we move on with nasal packing. Then we observe for that patient any rebleeding is there. So again patient had rebleeded. We asked the help for ENT also.
Patient's nose was packed, right?
Then again patient had posterior bleeding is there.
Posterior bleeding, okay.
So we go with help with the ENT also. Then they admitted the patient for 48 observation.
Did they remove the nasal packing?
No. Already pack is there, so they go for admission and they ask to under GA they will explore the patient.
So patient was having active bleeding even after nostril packing.
Nostril packing. Recurrent bleeding is there. History also is there.
Previous history. So previous history, recurrent bleeding from where? Any previous angiograms done or DNAs done previously?
No, sir. Just went out to the hospital, then shifted here. That time it was stopped. Then again rebleed was happened.
Okay. So after in GA they explored.
And they cauterized the sphenopalatine artery.
Okay. You got the bleeding point where?
There is a patient sample is taken. Anterior septum there is some crust areas there and blood clot is there.
Anteriorly.
Anterior superior septum.
Anterior superior septum near the frenulum. Near to the frenulum.
Superiorly. Coming to the sample history, 61-year-old male patient, known comorbidities, presented to ER with complaint of bleeding from the left nostril. Patient had history of recurrent upper respiratory tract infection 4 days back, and he had inserted toothpick inside his left nostril for removal of the crust. Then followed by he noticed bleeding from the left nostril. He initially went to outside hospital. From there he was done, packing was done. Again rebleed was done. Patient came to our hospital. There is no any past history of similar episode. There is no any regular medication also.
Packing was done from outside hospital. When?
That is 2 days back.
Okay, so after that their ENT surgeon removed the packing.
And when discharged, not discharged, went to not admitted in that hospital. 24 observations done. Then he go to home. Then again rebleeding was happened. He came to our hospital.
Okay. Okay. Impression?
Posterior, most probably posterior bleeding is there. Epistaxis with the left posterior bleeding. They done it under GA. They explore the patient with cauterization of sphenopalatine artery.
Okay, so suspected posterior ENT epistaxis. Okay. What are the blood supply to nasopharynx?
Nasopharynx mainly sphenopalatine artery, sphenopalatine artery, diaphragmatic artery, superior labial branch of facial artery, anterior ethmoidal and posterior ethmoidal artery.
Where are all these blood vessels going?
Most commonly supplied litmus plexus. The litmus plexus supplied by anterior ethmoidal artery, superior branch of facial artery, greater palatine artery, and superior palatine artery.
Okay. Posterior bleeding? Posterior bleeding point is?
Superior palatine artery, supplied by superior palatine artery.
Okay. So here, what do you think happened?
Patient had a recurrent upper respiratory infection. By the trauma history is there. Patient inserted one toothpick inside the nose that causes bleeding. I removed the crust, so it will causes the bleeding point. But patient also had recurrent bleeding is there.
Not very clear. See, what is the problem with this history? The history that you told, what is the problem here?
Basically, it causes traumatic bleeding.
Yes. If it is traumatic bleeding, where is the trauma that you are saying?
Anteriorly.
That is the problem. So, if you say a patient inserted toothpick to the anterior nostrils to remove crustaceans, why did he develop a posterior bleeding which required sphenopalatine artery ligation? That is the issue. The issue is not that he developed a posterior bleed. The posterior bleed treatment was sphenopalatine artery ligation. That means that is a direct communicating injury that is causing continuous bleeding, isn't it? What is the problem? Happened 2 days back. Patient already seen in outside hospital, packing done, was asymptomatic, pack removed and sent back to home. If it is direct trauma to spinophalangine artery, patient would have been bleeding, isn't it? Direct arterial bleeding. So, whatever outside hospital done with the compression and packing, patient's bleeding had stopped. That's why they removed and sent the patient back to home, right? So, it might have been a clot, unstable clot, which has occluded the trauma point, and after some time the trauma might have, the clot might have got popped and bleeding started, or patient might have inserted its finger or some other foreign body, or might have sneezed or cleared his nose forcefully, or else subsequently also patient developing a posterior bleed, very difficult with this history. A direct trauma causing acute spontaneous hemorrhage, uncontrolled hemorrhage is very easily explainable with posterior bleeding. This is 2-day-old history. That's why I asked, where did you find the bleeding point? Now, did you find a bleeding point in the anterior nostril? You told, no? Was it a clot that you found, or was it blood smear that clot was found? Then, according to your examination, patient is having 2 bleeding points. One in anterior, one in posterior. Spontaneously, patient might have blood. Cannot attribute it to trauma. If you are having 2 different bleeding points, cannot attribute it to one episode, because he inserted it only once, right? Okay. So, blood supply, as you told, we have 3 major arteries. So, in that, spinophalangine artery is most commonly associated with posterior bleed, while ethmoidal and facial branches are more commonly with the Little's area. Little's area is basically what? It's a capillary plexus, right? Isn't it?
No.
Yeah, where is it situated?
And superior to nasal septum.
Anterior to the nasal septum is where it is located. What is the classical features of a anterior Little's area epistaxis?
Bleeding was from anteriorly.
Classical features of Little's area epistaxis. How will the patient present?
There is an history of trauma.
Can be with the trauma, can be spontaneous.
Bleeding from anteriorly, not posteriorly. Bleeding from anteriorly is there.
That much only. Usually bleeding is controllable. Bleeding is controllable. Multiple previous episodes would have been there, and each time patient himself would have been exposed to the rescue techniques. This much is most common. Posterior bleeding is usually multiple episodes wouldn't be there. Whatever episode, if it is uncontrollable, patient would have already been evaluated and would have taken for ligation. This case, that's why I told it's not very clear as such, but multiple posterior bleeding points are very unlikely. Anyhow, and more amount of fluid not able to control with the nasal compression, means compression to promote clot formation will not stop the bleeding. This patient, on presentation, patient was having active bleeding for some time, or patient controlled and presented to us?
An active bleeding, patient came with active bleeding.
Active bleeding. Any, what was the vitals at that point of time?
160/90 BP, saturation was maintaining, 96 is room air, the heart rate is 96.
Okay. So what we are given for BP control? Is BP control necessary for these epistaxis patients?
BP control necessary is there, but for 160/90 we can again recheck the BP. It is again high. We can give anxiolytic drugs, or we can give antihypertensive medication like IV medication we can give.
Do you think this epistaxis was caused by antihypertensive drugs? Was caused by uncontrolled hypertension?
No, sir.
Why?
Basically, hypertension is a risk factor. It is not a causative factor. It will cause prolonged bleeding is there.
So, hypertension as such doesn't cause spontaneous epistaxis. If it is epistaxis would have been a feature of what?
Every hypertensive emergency.
It would have been a feature of hypertensive emergency. No, hypertensive emergency is saying that there will be epistaxis. So hypertension as such usually would not cause
Epistaxis.
epistaxis, but epistaxis flow of blood will be increased if patient is having higher blood pressure. Usually patient's blood pressure will be elevated during epistaxis. Why?
Because seeing the blood anxious.
Anxiety. So the drug of choice will always be anxiolytics. If you told 10 minutes you give a compression and patient stopped bleeding, if a patient with anterior epistaxis presents to you, previous episodes of anterior epistaxis presents to you, you give compression and bleeding stops. What is your next step?
Bleeding stop, then we can explore the nasal cavity
Why you want to explore the nasal cavity?
to know from where it is bleeding.
Bleeding has stopped, right? Try not to disturb the area. That's the best thing you can do. You really don't want, because bleeding has stopped. Patient gives multiple episodes of previous anterior epistaxis picture. You really don't want to explore the area. You can observe the patient for some time for rebleeding. If not, you can send the patient back. Do you want to pack the nose? You want or not?
Anterior epistaxis.
Anterior epistaxis, you don't have to pack the nose unless patient is having recurrent bleeding. So the first episode of bleeding, if you can control with the compression, you really don't want to pack the ear. You can tell the patient there is no requirement for packing ear, there is no emergency here. Keep him under observation and clearly tell not to disturb the nasal region by blowing or sneezing the nose and all. Don't do. And you can refer the patient to ENT OPD the next day to do a DNA to identify the causation, bleeding, cause for bleeding and the bleeding point and all can be evaluated. There is no emergency there. But the same patient is presenting to you repeatedly or presenting to you another episode during observation time or after discharge, presenting to you, then you have to pack the nostril. Okay, so how do you pack the nostril?
We can commonly use Marosil packing. We can use.
We use Marosil packing. Traditional packing methods are there, but that is very difficult to do in ear. So we use Marosil. It's an expandable gel form. So you insert into a bleeding nose, that blood itself is enough to expand the Marosil and completely pack the nostril. Once packed, what is the plan?
Don't remove within 28 to 48 hours.
Do not remove it for next 48 hours. Tell the patient, ask the patient to take drugs properly for antihypertensive drugs properly and discharge the patient and to come to ER if bleeding happens again. You observe the patient and come to ER for reassessment if bleeding happens is the only thing you need to do. During your observation time, patient again bleeding. Where should you suspect bleeding is from?
Anterior packing was done, then again
Yes,
bleeding is
this
done.
patient, anterior packing was done, again patient is bleeding.
Posteriorly, we will suspect bleeding.
Yes, then actually you should remove the packing and do a posterior packing, because if you are having, you can have bilateral like anterior and posterior epistaxis you can have. You are more concerned about posterior epistaxis because that is an uncontrollable epistaxis. That is the one that can cause aspiration. That is the one that can cause hemodynamic instability, desaturation, everything. You don't expect that from anterior epistaxis. So you should not be like, I just packed the nose so I won't remove it. You should remove it and pack the posterior nostril first, because only way to pack posterior nostril is through anterior nostrils easily. Otherwise you have to intubate the patient and do for DNA, isn't it? DNA packing is the only other way to pack the nose posteriorly. So here we could have packed the nose posteriorly and reinserted anterior packing, because patient's bleeding won't contained, no? So I don't know why we didn't do that. We could have done that because the same effect. And if posterior packing also is not controlling the bleeding, then patient needs to be taken to OT in an emergency basis. Otherwise, you are saying that bleeding is there, we can wait and watch. While there is no compression given, patient high risk of aspiration, patient can be kept on a supine position. There's a lot of complications, no? And you are admitting the patient, isn't it? Okay. So, if at all posterior bleeding is there, what else can you do?
To control the bleeding, we can insert a Foley's catheter,
Okay.
a 14 French Foley's catheter we can insert. We can insert through the anteriorly, then inflate the balloon with
When will you inflate the balloon?
after reaching at the posterior nasopharynx.
How will you know?
Through by the mouth.
So, ask the patient to open the mouth. Insert the Foley's while opening the mouth, so that when you see the Foley's in the pharynx,
Pharynx.
oropharynx, you can know that it has crossed over. Then inflate and
then pull back the for 2
Foley's through the nostril.
to 2000. We
Pull
can
back the Foley's through the nostril, so that
block the
compression will be given on the posterior end. So blood won't go to the posterior pharynx and patient will not aspirate on that. That's what we are giving. We are not giving direct compression. We are preventing blood going into posterior pharynx and aspirating. And pack the anterior nostril. Isn't it? Okay. So, even after Foley's, if bleeding is happening, what can you do? Or even with the Foley's, if Foley's compression patient is having bleeding, or along with Foley's compression, what else can you give? Patient is bleeding, man. What is the most common drug you give for bleeding patients in ER?
Tranix.
Why are you thinking this much to give Tranxa? You give Tranxa. You give IV Tranxa 500 mg in 100 ml over 30 minutes. Slow IV infusion. Why slow IV infusion? What is the side effect of tranexamic acid IV bolus? Hypotension. Tranexamic acid can cause hypotension. That is why in polytrauma it is written tranexamic acid IV infusion to be given over 1 hour. Okay, so here 1 hour, 30 minutes, at least 30 to 1 hour should be, 30 minutes to 1 hour should be taken for infusion. Don't give it as bolus. Okay, it's not a dose dependent drug, no? Fine. So tranexamic acid you can give. Then, when will you plan to intubate this patient?
Active bleeding is there and is not able to maintain the airway, we can go with on intubation. Aspiration risk is there, we can go with intubation.
Aspiration risk is always there for a posterior bleeding
Exploration
patient.
of posterior bleeding under GA plan is there, then we can go for intubation.
Either electively END is telling that they are taking for exploration, you can intubate the patient, or else they want angiogram, in which patient is shifting out of emergency department to radiology. If patient is actively bleeding and has high risk, you should secure the airway. Otherwise, inside ER, only time you need to secure the airway is when you have increased aspiration risk due to either increase in volume or due to decrease in sensorium. Otherwise, you don't have to intubate. Okay. Anything else? What are the, if it is first episode of epistaxis for a child, okay, maybe like 4-year-old, 5-year-old child, what other things will you do? Or will you ask? What other things will you ask? What other things will you do?
History, trauma history.
Yeah, trauma history, children trauma history can be asked. Adults also you should ask. But what else? That's not a new thing, no? Foreign body insertion should be asked. Young children, the first and foremost thing you should ask is whether they were playing with the small things that they have inserted. Patient will be presenting with the anterior epistaxis or even posterior, but there will be a foreign body lodged there. Problem is that if you don't ask that and try to pack the nostril, there will be significant trauma. Isn't it? Merosil, right? It will expand. If there is a foreign body there, what will happen? So you will be trying to push in merosil to a nostril which is already having a foreign body. So that history should be asked. What else? Maybe much more younger child, 3-year, 2-year. Yeah, you should ask for other cut injuries, other easy bruising, ecchymotic patches, many other cut injuries that require prolonged time for bleeding control. Can be hemophilia, right? Children. So you should look for hemophilia also in them.
Adult.
What about in adults?
We can ask about drugs causing anticoagulation, antiplatelets.
So these things should be asked. Antiplatelets should be asked. Anticoagulation should be asked, isn't it?
Any-
So if patient is taking warfarin, what will you do? What will you do?
if INR is in anterior bleeding, INR is in desired level, we can continue warfarin. If the INR is-
Patient is having this patient posterior bleeding. You are packed. Patient is still bleeding. Okay, you are given transfer. Patient still bleeding. Patient is on warfarin. What will you do?
clotting factors and injection vitamin K, we can give.
So you will reverse warfarin effect. You don't have to stop the drug. You check the INR. If there is no toxicity, you should not stop the drug.
Desired level.
Patient should be taken for surgery, exploration. Okay, because patient is on warfarin due to a systemic cause. This is a controllable area of bleeding. Patient should be taken for exploration. You don't have to reverse. Reversal of warfarin is only indicated when there is systemic bleeding which will cause hemodynamic instability. Otherwise, you don't. Okay. Antiplatelets. Will you stop antiplatelets? Anterior epistaxis patient presents to you. Patient with compression bleeding is controlled. You are telling review in ER if bleeding recurs. Patient is telling that I am on aspirin and clopidogrel. What will you do? Stop antiplatelets and discharge, or ask them to continue?
Anterior bleeding control, no need for stop.
No need to stop. You can continue. Even if there is recurrent epistaxis, you don't have to stop antiplatelets. If the same patient is presenting to you multiple times, you can stop one antiplatelet, but you should always continue at least one antiplatelet. Only one can be stopped, not both. Okay. Anything else is there? Okay.